Welcome to Cruise Through HTX. My name is Freddy Cruz, and this is a podcast about the organizations, businesses, and individuals that make the greater Houston area great. Today, I welcome to the show a new podcast partner. As you know, I have a media company. It is Speke Podcasting, where we produce podcasts for various clients. I welcome Dr. Patton Jr., the forthcoming host of the podcast, Your Health, Your Wealth, which will be hitting your favorite podcast platform this summer. Dr. Patton is a neurologist, but he's also got a very keen interest in sharing with the public all things healthcare economics. During this episode, we're going to talk about what led him down the path to neurology. We're going to talk about best practices for taking care of your mind, all that and more. You can check out Dr. Patton at Eddie, with an IE, PattonMD.com. And if you enjoyed this episode as much as I did putting it together for you, please consider sharing with your family and friends from my website, cruisethroughhtx.com.
Hi, I'm Ed Sheeran. This is Bruno Mars.
Hey, it's Katy Perry.
This is your man Flo Rida with Freddy Cruz.
This is AJ Mitchell with Freddy Cruz.
Freddy Cruz.
Freddy Cruz.
Tell your Chico pick Mr. 305 and you already know what it is.
My name is Freddy, and it's time to cruise through HTX. What were your thoughts going in to see your first patient?
Wow, that's a really good question, and it's hard to think back that I'm kind of dating myself as far as thinking back that but I do remember very vividly one of the first patients that I met, and I met this lady in the emergency room in Detroit. I was doing an emergency room rotation, but it was an older African American female. She was there with her son, and unfortunately, we found that she had a rupture in her aortic artery, which is her aorta, which is a main artery there in your body.
Kind of a big deal.
Very big deal. Very big deal. And I remember, the reason I remember this so vividly is because I was excited because I found this thing, but I wasn't really prepared for what was next. And when I talked with her, and I said, Mrs. Such and Such, I found what's going on, and you have this artery, and we can do surgery, and we can potentially fix this thing. And she said no. She said that she didn't want to have surgery. She had lived her life. She was happy. She was comfortable with her family and her spirituality, and that after talking about the surgery and the risk of what could go bad, she decided she didn't want to do it. And I remember that story so vividly because it was one of the first experiences that taught me that even as at that time I was a medical student, that it's still a patient's choice. And I spoke with her son. Her family was happy with her decision. She was older, advanced life, and just didn't want to do it. And I still remember I would visit her every day in the hospital, and she would sing hymnals with her family, and she was so happy. And she, she passed during that hospitalization, but I still remember that case very, very vividly, and it was a good case for me, and she was a good patient for me to meet early on because it taught me that, when it comes to life and healthcare, we put so many resources into the most advances in MRIs and tests, and we can do this and we can do that. But in the end, it comes down to the patient's autonomy and what they want and what they believe. And it's okay if you say you don't want to have these extraordinary procedures and so forth.
That it's okay to fire the doctors.
Yeah, absolutely.
Okay, so I want to back up a little bit. How long, so you say this patient was advanced life, so I imagine that might mean older than 70, but if it's a ruptured artery and, I'm 48 going on 49, something like that happens to somebody like me, a young buck, so to speak.
Yeah.
What's the difference in being in your 70s or 80s versus your 40s and 50s, like how survivable is a surgery like that?
Well, yeah, I mean, surgeries like that, this was a pretty complex surgery. Don't get me wrong.
So even for someone like me,
yes,
still very high risk.
yeah, it's still high risk, but I will say this was several years ago. We made advances in surgery, number one, and number two, the chances of your survival, they increase based on a couple of things. Do you have overall good health, your age, those type of things.
Mm-hmm.
So yes, her scale or her risk was much higher than your risk would be. Mm-hmm. Absolutely. And in that situation, when she looked at the risk versus the ability to just spend my last few days or whatever with my family and be happy, she chose to do that as opposed to put herself through the risk of that surgery.
Okay, so you were at the ER, and so was this before you decided to go into neurology?
Yes.
Wow. It's interesting. It's interesting because I've got a podcast partner, Dr. Angela Sturm, who's a facial plastic surgeon who thought she wanted to go into ER, and it was one of those things where it was just too much uncertainty. So let's say Freddy is in the ER for whatever reason, and she will treat Freddy, but not really know, like, what happened to Freddy 2 weeks later? He got into a wreck, and we helped him with a ruptured whatever, aorta. And I think he's okay because he was young and he looked like he was in shape, but I don't know. And so, it's funny because we had a talk on one of our 2 interviews that we've done for my show, and it's like, it's closure that I guess she kind of desired. As a facial plastic surgeon, someone goes in, Freddy goes in, I want a new nose. Oh, I can do that. Rhinoplasty. That's what I do. You get the closure because you see the before, you have a determined outcome that you want, you get the determined outcome, and there you go.
Yeah, and it's funny because in this situation, it did teach me a lot about myself because I too like that closure. When I kept seeing this particular patient after she had been admitted, I was still doing emergency room. So I was just going up just to see her on my own because to me it was such a spiritual thing. It was such an eye-opening thing, and we did establish somewhat of a rapport. I still remember her telling me how proud she was of me, and she didn't even know me. But as a young African-American male in medical school, and she just kept saying, "Baby, I'm so proud of you." And
man.
And so I would still go to see her. But choosing your profession in medicine, there are a couple of things you have to think about. Your personality. And to be honest with you, I had classmates that, I'm going to put this in the most kind of political sensitive way I can, but they didn't really like dealing with people.
Gotcha.
And they didn't have very good people skills. Mm-hmm. So they were able to go into things like radiology or pathology where a lot of times you don't have to really interact with patients that much.
Yeah.
And that was one of the reasons why I chose neurology. I was very good at surgery, and I was thinking about either neurosurgery or family practice going into medical school. And neurology is right in the middle because I like the investigative piece of medicine. I like getting a challenging case and trying to figure it out. And neurology was perfect for me from that standpoint.
It's like a 10 million piece puzzle, I guess.
Absolutely. So there's some fields where it's a 3-piece puzzle. It's like, all right, you know what the problem is, do this.
Yeah.
And you're skilled. And in those physicians are very highly skilled at what they do. But, in neurology, we see some of the weirdest cases. I mean, it's usually the field where no one else can figure it out. And they're like, yeah, go see neurology.
Oh, goodness. Okay, so with neurology, you're obviously studying the brain, and, the human brain is just so complicated. And I think you spend a day in Houston and you really understand, just how complicated we humans are. But, I mean, you told me about the first patient you ever saw, ER. What about, so now we're going into your specialty, neurology. This is what Dr. Patton wants to do. This is what he chose. talk about the feeling when you treated your first patient. Like, how did that go? What were the similarities and differences between the aorta lady and this one?
Yeah. Well, if I were to back up to really say what got me interested in neurology, it was actually, I think, probably late high school, going into when I graduated from college. And that was when my grandmother was actually first diagnosed with Alzheimer's disease. And so I watched her throughout the course of the next, 10 years of her life or whatever. And then while I went off to college and come back and watch her go through the processes of Alzheimer's disease and dementia. And to be honest, that's what first got me interested in the brain and how it works and how it affects our memory and everything else. So she wasn't my patient, but fast forward years later. So even going into medicine, I knew that I wanted to look at the brain, or I wanted to do something in that field as far as the neurosciences. My first patient in neurology, though, I think was a migraine patient. It was a simple headache. And in that situation, it's about coming up with a diagnosis, and then you have actual treatments that can help them. So that was the difference between that first neurological case and that case as a medical center in the emergency room, where in both situations, I was able to find out what was wrong, and I can say, I know what I can do to help you. But when you're dealing with surgery, a lot of different things you're looking at, risks that go into it versus here, you can take this medication and you'll get better. It was just two different dynamics there.
Is it true Botox can treat migraines?
Absolutely. I do Botox for migraines. Wow. It's an interesting story. They actually found that out because, so many women who had migraines were getting cosmetic Botox, and they were like, my migraines are better. They looked at it specifically in migraines, and it's been approved now for the treatment of chronic migraines.
So it just happened to be somebody who liked cosmetic surgery.
Well, they were getting Botox for cosmetic reasons, absolutely.
Wow.
But it works. It really does work. And what I do like about it is it's pretty safe. It's not the most. It is a little uncomfortable for patients because you're given a bunch of shots around the forehead, the back of the head, the side of the head. But it gives you have to do it every 3 months.
Yeah.
But patients that I've done, it really works.
And what about people who know for a fact, like me, like if I had migraines and I don't want Botox because I don't want to look like someone from the Oscars,
Yeah, absolutely.
Then what do you tell somebody? It's like, hey, look, it's pretty, it's relatively low risk, or there's this other medication with all these side effects. What do you tell somebody who's on the fence about that?
Well, the beautiful thing about treating migraines is we made a lot of advancements in treatments now. We have these newer treatments called CGRPs that have come out in the last couple of years. So before, there's two ways that you divide treatment up. Episodic treatment, meaning you start to feel the headache coming, you take something, versus prophylactic treatment, meaning you take this either every day or once a month to prevent from the frequency and the intensity of the headaches. So when you divide that up in migraineurs, it's usually not hard to sell the story because these are very distressing situations. These are usually people in their most productive years. They want to get back to work. They want to get back to taking care of their children. So if I offer you something that says I can reduce the frequency of your headaches from 20 per month to 10, then most people say, hey, give me that.
Yeah.
So for the most part, when it comes to the prophylactic treatment, it wasn't that hard to sell, especially when something is safe and doesn't have as much side effects.
What is your favorite development in neurology since you started?
Man, that's a tough one because neurology. So I'll give you a little bit of history. When I started training, neurology was known, and it's still known as this cerebral field, meaning that we're the thinkers, we like the tough cases, but it was also known that you can't do anything about the stuff so we find out what it is, and we do all this cool stuff, and we can tell you what's wrong, but then we can't do anything about it.
Yeah.
Well, I can say that has really changed throughout the years, the 15, 20 years that I've been practicing. When you look at something like multiple sclerosis, when I was training, there was literally 4 drugs for MS, essentially. I mean, there was other things you can do, steroids, but there was Avonex, Beta Serum, Copaxone, and Rebif. Now, man, it seems like there's a new one coming out every month. So, and the same thing with migraines. And for my specialty, neuromuscular myasthenia gravis.
I'm sorry, say that 10 times fast.
I love MG. You could just say MG for myasthenia gravis. But so the biggest advancement for me is that we have these new treatments, monoclonal antibodies, IV treatments for these conditions that for years we really didn't have a lot that we could do for these patients. Now, in some conditions like ALS, we still got a ways to go. Mm-hmm. But I can truly say over the course of my year, the course of my career, the advancements in treatment has made neurology a very exciting field.
What are your hopes for Alzheimer's?
Yeah. Number one, if you look at the number, just look at the number in our population with baby boomers. By the year 2050, and I don't have them on hand, but the number of patients with Alzheimer's disease is going to be at a pace where it's going to, if all these patients are on Medicare, it's going to be hard to treat economically for the country. That's just because the number one risk for Alzheimer's disease is aging. So as we get older, our risks just increase. So we're living longer because we made advances in treating diseases like cardiovascular disease and so forth. But now these neurodegenerative diseases like Alzheimer's disease and Parkinson's disease, we've got to find an answer. And we're doing that in the past couple of years. There have been new medications that have come out, these so-called anti-amyloid autoantibodies. The most recent one approved, I've used several times, and it works. So as opposed to just giving a medication that hopefully will slow the progression, we're actually making people better. Mm-hmm. And there's still some work that needs to be done on those, from risk factors and everything else. But now we're seeing the research, we're seeing the advances, and hopefully we'll see the same type of effort, and we see the same type of stacking of treatments that we saw with migraines and MS, where you'll start seeing more and more of these treatments coming out, and they'll get better and better and better, so that hopefully, by the time you and I are more advanced age, we'll have something that can reverse this.
Yeah, that scares the crap out of me because I've got a sweet tooth, and I know that Alzheimer's and dementia, it's been referred to as type 3 diabetes.
Yeah. And
of course, how do you get diabetic? Eating a little bit too many sweets, probably. I do love me some exercise. I'm not necessarily one of those gallon of Bluebell every other day kind of people.
Yeah.
But I like to treat myself. And so I kind of am at peace with having a little bit of a sweet tooth, but also making other really good decisions as far as, not drinking, not smoking, not a lot of red meat, eating, I guess, a little more plant-based food than maybe the typical person would. I find that I kind of, depending on who I'm hanging out with in my family, gross people out because I eat, because I talk about whatever vegetarian or option that we're having or whatnot, So yeah. It's like, kind of tells me that I'm directionally correct.
Gotcha.
But, what do you say about like diet? Like, how much does diet come into play when it comes to preventing this kind of stuff?
Sure. Diet has a huge impact on our health long term. When we think about the key to aging, everyone's looking for the fountain of youth.
Yeah.
And the two things I would say is exercise and diet. You mentioned ice cream and a sweet tooth. That's not the only thing with carbs that you have to be careful about. And that's where sometimes people get in trouble. A lot of pastas, other food, root-based things like potatoes and so forth. You really have to look at the macronutrients in everything that you eat, because you can cut out ice cream and Bluebell and still have a lot of carbs that can lead to increased diabetes and different things like that. So really educating and learning about what are those macronutrients and then the proportions. It's okay to have a blueberry once a month or something. I do.
Once a month?
And I love, and look, I'm even worse. I get in trouble because I go get magic shell topping and put on it, and that's my treat. But as long as you do it in moderation, that's the key. But also watching the other things that you're eating and just making sure that it's not a heavy carb load and those type of things. And those things as well.
It seems like what gets us, Dr. Patton, is the fact that there's added sugar in everything.
Yeah.
I mean, just if you have a sandwich and you think you're having grilled turkey with Swiss cheese and low-fat mayonnaise or whatever, and lettuce and tomato and all the good stuff, and you're having it on regular bread, and there's a solid chance that there are 4 grams of added sugar in that.
Yeah, processed foods. You have to think about how can this stay on the shelf for this long.
Yeah,
there's things added. So fresh leafy green vegetables are always usually the go-to route because years ago, the powers that be and industry and everything else realized that sugar is addictive, and there are things that you can add that makes me want to go back and get that second bowl of Fruit Loops or whatever.
Yeah.
So we just have to learn to be disciplined.
I think he's inferring that Fruit Loops are not made of actual fruit.
It's not fruit. And that was my thing, man. I used to eat Fruit Loops for lunch. I could eat Fruit Loops 3 times a day. and I had to quit getting it for my kids because they like, it's like, who ate up all the Fruit Loops? You go in there and it's like 3, you can't even make a bowl at the bottom, but they put the box. That's usually me because I was too ashamed to throw the box away.
Oh man, you were that guy. You were that guy in the house.
Yeah, that was me.
I got a wife and 2 daughters, and one of the 3 is always pulling that somehow, and it's like, what? Yeah. Oh goodness.
Just finish it off. I mean, it's not even enough to make a bowl. Just finish it.
Yeah. Oh man. Okay. So one last question before we wrap up the interview. I am a fan of what Neuralink is doing. With the microchips, and I know that probably sounds weird coming out of my mouth, but I heard the first chip, it was a guy who got paralyzed from the neck down, I believe, or the shoulders down, in a diving accident. And they implanted a Neuralink chip in his head, and he was able to play chess using his brain. What are your thoughts on that?
People think of things like Neuralink as science fiction, but when you truly understand the neurological system, your nerves are circuits, and it's electrical signals. And the spinal cord is like a highway. It's carrying those signals up to the brain and then down out into the body, like a two-lane highway. So if you can find a concentrated area of those circuits, like in the brain, and you can impact them, there are amazing things that you can do. There's a term called neuroplasticity, which means your brain can adjust. There's a book, I'm forgetting the name of, The Diving Bell and the Butterfly, or something like that, but it was about a man who had locked-in syndrome years ago. I think he was in France, and he wrote a book using his eyes and eye movements to write an entire book about his experience. So it is, when you think of technologies like Neuralink, and there are a number of technologies. I mean, artificial intelligence is going to change not only the fields of neurology, but psychiatry and a number of other fields in medicine as well. It's something that we need to be excited about. We have to be careful. There are a lot of ethical implications and different things that we need to work through. But I think over time, if we keep the patients first and we have physician leadership that can really steer this in the best ethical way, it's exciting. It's really exciting.
Love it. I'm optimistic too. I mean, 124 years ago, I'd be categorically dead based on statistics. Life expectancy was garbage.
Yeah.
And now there are chances that I could live not just past 100, but upwards of maybe 110. If I can just kick the sugar habit maybe and work out a few more times a week. I don't know.
Moderation.
In moderation, I guess. Yeah. I mean, you got to, hey, look, you still got to be able to have fun.
Yeah.
It's my defense. It's probably a bad defense, but no, I mean, I think it's a wonderful time for all of us to be on this planet because, it's beats the alternative.
Yeah.
I mean, good Lord, I'd hate to, be alive back in the early 1900s when life expectancy was garbage.
Yeah. I would say if we can really shift resources and really think about preventative care,
Yeah.
and figure out ways to incentivize preventative care as opposed to catastrophic care. ICU when the bad stuff has happened, when the diabetes has led to the stroke and everything else. That I think is the key to healthcare, because everything that you're talking about is preventative care. How do we teach about eating, exercise, these different techniques, mindfulness meditation? It costs you nothing, but can really help with things. We've even done studies and found that it helps with migraines. We were talking about that earlier.
What?
Absolutely. So that to me, though, when you talk about longevity and everything else, if we can find ways to really teach and preach preventative care, we'll find that key to living a longer, healthier life.
I love this. I already know for a fact I'm going to have you on my podcast. We're going to talk more about like the brain and all this other kind of stuff. I have so many questions for you, Dr. Patton. You got to check him out on the interwebs. He's got a series of videos out, and he's got a lot of knowledge to share with you all. So please give him a look on his website. Thank you so much for everything, sir.
Yeah, thank you for having me, Freddie. I really appreciate it.